Good morning, everyone. We're just going to give a few minutes for all the attendees to continue to join. We'll start in just about 2 minutes. Okay, welcome everyone. I am Harry Canan, Regional Resource Director for Caron Treatment Centers serving the state of New Jersey. Thank you for joining us for the 20th installment in our webinar series, A View from the Mountain, Caron's Perspective on Addiction Treatment in the Wake of COVID-19. And today's topic, Understanding and Treating the High-Functioning Alcoholic and Addict. Today's presentation is eligible for 1 hour of social work continuing credit. We would like to thank our educational sponsor, Jumana Grassi, for assisting in obtaining these credits. Please keep your Zoom session open at the end of the presentation to access the post-event evaluation to obtain your 1 hour credit. In order to receive your credit, you must stay on for the duration of the webinar. An email certificate, a certificate will be emailed to you from Jumana within the next 2 weeks. As a reminder, we will be conducting this session in webinar format. All participant microphones will be muted. During the presentation, please utilize the Q&A feature to ask any questions that you may have. Depending on the volume of questions, if we can't get to your question before the end of the hour, we will have someone from our team follow up with you directly. Today, we welcome 2 presenters, Dr. Caron and Samantha Smith. Dr. Ayer is the Executive Director of Ayer Counseling, his full-service private practice in Morristown, New Jersey. He has spent the last 30 years working with adults, adolescents, couples, parents, and families in a clinical setting. As a preferred provider for executives and professionals seeking mental health and substance abuse services, Dr. Ayer serves his clients in a discreet manner, affording them with the comfort and confidentiality to address their particular concerns. Dr. Ayer is recognized as an expert in the areas of co-occurring disorders, treatment, and alternative substance use disorder treatment approaches. In addition to his clinical practice, he is a professor at both Rutgers University School of Social Work and Rutgers University Center of Alcohol Studies. Joining Dr. Ayer today is Samantha Smith, Executive Director of Caron's Grandview Program, a signature inpatient treatment program for individuals affected by substance use disorder that keeps privacy, comfort, and flexibility top of mind, while also being attentive to personal and professional experience, background, and life goals. Sam has 11 years of experience in the field of substance abuse and addiction treatment, 8 of which have been working exclusively with adult men at Caron. She also specializes in addiction interaction disorder and has clinical experience in both motivational interviewing and experiential counseling techniques used to support and affect regulation and emotional sobriety. Please welcome Dr. Caron Ayer and Samantha Smith.
Thanks, Harry. Welcome everybody this morning to our program. And what I'm going to do is talk to you a little bit about sort of the phenomenology of high-functioning addicts and alcoholics. So what I hope to do is to be able to give you a little bit of a primer regarding this subtype of SUD case. And so I think there's just a couple of things I'd like to sort of maybe ask us to think about as we begin to explore this topic. So one of the things is that substance use disorders take on different types of profiles. And the way I like to kind of think about it is that there's not one type of substance use disorder, there's not one type of cancer. Is that there are different types of cancers that vary in terms of intensity, severity, prognosis, and how it is that you'd go about treating them. So for example, somebody might get a very unfortunate diagnosis of stage 4 pancreatic cancer. And I think as many of us know is that that diagnosis offers a very poor prognosis, and that the disease will likely take that person's life very rapidly. Alternatively, is that somebody might go to a doctor and get a diagnosis of a basal cell on their forehead or on their cheek from a little bit too much sun at the beach. And that type of diagnosis is very treatable, and in most cases doesn't represent a risk to loss of life or a major intervention beyond having the cells taken off the body. So substance use disorders are much the same way. There are some substance use disorders that the prognosis is unfortunately rather grim. People who start very early in life, people who have severe co-occurring disorders, where there's an aggressivity to the substance use. Those are complicating factors that could make that prognosis poorer. So again, one of the things for us to sort of think about is the fact that there is not just one type of substance abuse problem. There are different types of substance abuse problems. So when I started in this field in the early 1980s, is that all substance abuse cases sort of came in and received much more or less the same treatment. So I worked in a rehab program in Maryland where a 25-year-old opiate addict sat next to a 50-year-old executive, and that they attended the same lectures, they had the same counselor potentially, they had the same care plan. And I think that one of the innovations that sort of occurred in treatment over the last decade or so is the development of specialized services, recognizing specialized populations. And very good programs like Caron Treatment Center have specialized programs and have specialized services, from young adult program, relapse, executive, older adult, and so on and so forth. So one of the things that's important when kind of taking a look at high functioning addicts and alcoholics is sort of, trying to develop a profile of who we're dealing with. So if we could turn to the next slide. So the National Institute on Health and NIAAA defines 5 major subtypes of SUD problems, substance use disorder problems. And I think that one of the subtypes that you'll see there is a functional type of alcoholic or addict. We've done a lot of great work in the treatment field and in the prevention field of raising awareness and sort of reducing stigma around substance abuse and mental health problems. However, there still is a great deal of bias regarding these diagnoses. And so oftentimes movies, books, and people's own experiences, when they think about an alcoholic or an addict, they think about the lower end of the functional spectrum. Think about what used to be referred to as the skid row bum. And that those are individuals that have multiple complex, profound problems, and there are multiple dimensions of their life that are not functioning. So what we know, and NIH refers to that skid row bum, the common or the current nomenclature around that is chronic severe. And so chronic severe alcoholics and addicts represent less than 10%. The research supports 8 to 9% of the alcoholic population is in the chronic severe spectrum. What that means is that The rest of the people who have substance abuse problems are in a functional band. And the research supports that somewhere in the range of about 75% of people who have substance abuse problems are in a functional to high functional band. So if we think about a bell-shaped curve, right, from our statistics class that everybody loved in college, is that we have these tails, which represent the minority, the outliers, and then we have the bulk of the curve that represents the majority of the population. And so in the middle of the curve, what I like you to think about is that that's the functional band, right? Is that most people who have substance use disorder are in a functional band. And over on one side of the band is that we have a dysfunctional tail, right? And so those are folks that they have substance use disorder. However, their level of functionality, being able to hold jobs, staying out of jail, maintaining relationships, so on and so forth, that's severely impaired. On the opposite end of the tail, we have people who are high functioning, right? And so all of these people that are in the bell-shaped curve meet the DSM diagnosis criteria for a diagnosis of substance use disorder. The bell-shaped curve represents a functional spectrum. And so one of the things to think about with high functioning alcoholics and addicts is that they meet the same criterion as everybody else in that bell-shaped curve. It's just that they are either able to maintain functionality or give the illusion or the perception that they are maintaining functionality. The next slide, please. So one of the things to think about in terms of subtypes is that high functioning alcoholics are a subtype of SUD disorders. Within the high functioning alcoholic subtype, there is a subtype. And so we have two subtypes of high functioning. The first is fragile, and the second is sustained functionality. So high functioning addicts and alcoholics are the least likely people to show up in our public and private treatment setting. Is that if you look at that bell-shaped curve, most of the services across the United States are dedicated toward the more dysfunctional end of the spectrum. So high functioning alcoholics, there are less resources that are dedicated toward that subtype. And they're, for a whole variety of reasons that we'll get into today, less likely to pursue treatment. However, the high functioning alcoholics and addicts that do come into our treatment programs, rehabs, IOP programs, partial hospitalization programs, individual counseling programs, are more of the fragile, high-functioning alcoholic subtype. And so maybe as many of us know here is that one of the hallmark symptoms of alcoholism and drug addiction is loss of control, that the person does not demonstrate or display the ability to consistently and predictably control the outcomes of their drinking or using sessions. So fragile HFAs tend to have intermittent loss of control with regard to their use, and that their loss of control tends to become progressive. So I think like a good example of this is recently there's been a bunch of movies that have been made about rock star celebrities in the 60s and 70s. And one of the movies that has come out is about the story of Elton John's life. And a lot of that movie, Rocket Man, sort of depicts Elton John, in the thrust of his chemical dependency. And he is what I would kind of consider a fragile HFA. So is that, in the movie, what you see is somebody who is making music, he's making lots of money, he's functioning at a high level, yet he's chemically dependent. Fragile HFAs tend to have sort of a fall off the edge of the cliff experience. So they tend to have entourages, they tend to have other support systems that are in place that allow the addictive process to continue. So for those of you that have watched that movie, is that, you know that Elton John had, managers and friends and lovers and other people connected to the music bandmates and things like that, that protected him, right? Is that they allowed the addictive process to sort of continue, some for their own selfish needs and other because they thought they were helping him. But fragile HFAs tend to have an experience where they come to the edge of the mountain, they're not able to stop what's going on, and then they drop off into the abyss. And that's when those folks then show up in my office or go to terrific programs like Grandview that Sam runs and programs. Is that when they've hit some type of rock bottom or some type of consequence. The problem with it is this, is that we'll come back a little bit about finding treatment resources that are appropriate for HFAs. But my experience with many HFAs that are fragile is that they tend, by and large, to pick programs that are not appropriate for them. As I said before, is that the vast majority of substance abuse services across the United States are dedicated toward people on the lower end of the functional spectrum. And so HFAs will do one of two things if they're not steered appropriately, is that they will enter into treatment, but in a program that is a total mismatch socioeconomically for them. So they'll end up in a charity clinic or some type of program that works with medically indigent folks. And sometimes it's done intentionally, sometimes it's unintentionally. But the problem and the issue with that is that they spend about a week or two in an IOP program or a rehab that's dedicated that way. And they say, I'm not like this, right? I'm a 53-year-old Wall Street executive. This program is full of folks that are homeless or that, are indigent and so forth. And so they walk out of that program with a sense that, these are not people who are like me, and that it then further reinforces their denial about the fact that they have a problem. The second issue that I see with folks that have this particular subtype is that if they don't choose a charity-based program, they'll go to what I call a day spa. So they'll go to a rehab program that is uber high end. They spend $90,000, $100,000 for 30 or 45 days, and they eat filet mignon every night and eat lobster tails every night and have whirlpool baths and so forth. And I've worked with many of these folks that have done that, and they haven't gone to a single AA meeting over the 30 days that they've been there, or they haven't been exposed to any psychoeducation that's helpful to them. So the benefit potentially is that they dry out in a situation like that they, have an experience where they're abstinent, right? They're sober from the chemical, but they haven't done any kind of work or therapy. And so what happens is that they come out, and for the vast majority of them is that they just restart the process all over again. So the second type of a subtype of HFA is folks that have what's called sustained functionality. And so these are people that have a much slower and gradual deterioration over time. So rather than thinking about like the fragile as somebody that comes along and all of a sudden they have this dip and this drop off the face of the earth, people who have sustained functionality is that it's like an airplane that's losing 10 feet every minute. So is that the chronicity, the length of their functional alcoholism can be very, very long. With those folks, they're difficult to intervene with and difficult to find treatment resources with. As far as treatment techniques for men and women that have high functioning alcoholism or drug dependency, is that when we look at the whole the whole array of what constitutes functionality, their job, their income level, the trappings of what it is that they have around them. Oftentimes, these individuals are exceptional, right? So they've got a lot of things that many of us would want or aspire to. They've got lovely homes, they've got wonderful cars, vacation homes, their kids go to private schools, they've got scads of money in the bank, and so on and so forth. However, they drink in a way that creates dysfunction in their lives. And for most HFAs is that the last thing to go, the last thing to drop off is their job. And so that becomes, for a lot of American high functioning individuals, their job, their title, their income level is their entire identity. And that they preserve that. It's their last bastion of self-esteem and dignity. But where a lot of things begin to crack and begin to crumble is in the family. So I'll just give you an illustration of a guy that I currently work with. Is that work with a Wall Street executive. He's a C-suite guy in a Fortune 100 company. He's been on the face of Fortune magazine, Money magazine, Bloomberg a number of times, and his company is a household name. He makes multiple seven-figure salary, and his bonuses are in the tens of seven-figure bonuses. And he's an Ivy League educated individual, and he played Division I sports. He's a very, very charismatic guy, and just absolutely looks the part of a Wall Street executive, good-looking, chiseled jaw guy who could talk to pants off anybody. The only problem is that he drinks on a good night a pint of vodka, and on a heavy night, which is generally 3 or 4 nights a week, he'll drink a liter of vodka by himself. So this guy, he's got a great job. He has all the trappings of anything that you'd want to have around you, but he's no doubt got a very severe alcohol problem. And so how he came to me was that he lives in a 10,000 square foot home in a very exclusive community in northern New Jersey, and he had his car service drive him home. The driver picked up a liter of vodka, and the guy drank the liter of vodka in the car service from Manhattan to his home in New Jersey. And so he showed up at his home absolutely inebriated. His third wife met him at the door, who's 20 years his junior, and she told him that he wasn't welcome to stay in the house and that he could sleep on a cot in the pool house where guests change into their bathing suits. For 6 months, while I worked with him, he lived on that cot in that pool house. And so part of it for him was helping him understand that his drinking had created major problems in his marriage. So there's really kind of 2 things that go on for folks with this subtype. One is cognitive distortions. And so the cognitive distortion was that I don't really have a drinking problem, doc. What I have is a stress and a marital problem, right? Is that if I just learned how to kind of manage my stress a little bit better, and if I had a more agreeable spouse, I really wouldn't drink this way, right? And so part of it was, kind of working with him and trying to help him understand the fact that, your drinking is creating these issues. One of the things about HFAs in terms of treating them is that a lot of them, whether they're doctors, surgeons, lawyers, entrepreneurs, they've enjoyed a fair amount of success in their life. And treating them like they're a dummy and that, hey, listen, your way's got you nothing but drunk and take the cotton out of your ears and put it in your mouth generally doesn't work very well with these folks, right? Is that because what they come back with is that I've done a lot of really impressive things. I probably made more money last year than you'll make in your entire career. And so, what advice can you give me? And so one of the things that I tend to do with them is that as I attempt to penetrate some of these cognitive distortions, take a more consultative role with them, not to sort of prescribe cures and treatments and provide labels to people, but to sort of act as a consultant to help them achieve their goals. So, Harry introduced Sam, and he described her background as having training in motivational interviewing. And so MI is a terrific tool to work a style of work with these folks. The other piece that I see quite a bit of is people who have HFA who are stuck in a place of experiencing their alcohol use from entirely from euphoric recall, which again is another type of distortion that takes place, is that when any of us drink, is that there are good things that happen and there are not so good things that happen. And when people experience euphoric recall, is that all they're doing is remembering, right, selective pieces of the more positive side of the drinking experience. And so again, this is a distortion that takes place. And part of the intervention and part of the work with HFA is helping create a more balanced view, is that not just data mining and not just looking at the positive pieces that have gone on with the drinking, but also to look at the consequences. So there's a lot of different struggles and issues in terms of working with HFAs, and I'm going to let Sam kind of talk a little bit about the treatment side, but I'll just kind of give a lead in, is that, oftentimes, really with any substance abuse case that you work with, is that one of the primary features is, helping penetrate the patient's denial. And so part of the struggle with HFAs is that there's usually two aspects of denial. You have the primary denial of the patient, and then you have the secondary denial of the family member or the close friends and contacts of the HFA. And Sam will talk a little more about this, but oftentimes they're living a pretty good life, right? They're living in a luxurious home, they've got all the trappings around them and so forth. And that to take a hard stand and to address or confront it in a hard way creates a jeopardy to their lifestyle and to things that make them comfortable. So I think with that in mind, I'll hand it over to Sam, and she can talk a little bit about the good work she does at Caron.
Thank you, Dr. Eyre. Hi, everyone. I'm Sam, and I have been working here at Caron for past 12 years, and the last 5 of them on Grandview here at Caron on our PA campus. And Dr. Eyre and I have been working for a good many years, I'd say, since Grandview opened, in really establishing a continuity of care for the high-functioning alcoholic that Dr. Eyre talked about. And I think he really did a fabulous job of taking a look at what makes a high-functioning alcoholic. And what I want to focus on from a treatment perspective is really, what are the barriers that we see? What are the barriers that we see from an admission standpoint? How do we work with them from a treatment standpoint, and what makes their treatment look a bit different than someone that might be coming into a regular treatment component? So I think, from the door, a high functioning alcoholic from an admission standpoint is going to look different than another individual that may have their rock bottom may look very different. As Dr. Eyre said, their jobs are usually very well intact. There are usually very little consequences from the outside view. So image is probably being pretty significantly upheld, not only from the patient perspective, but also from the family systems perspective. I would say, I get a call, I get multiple calls weekly from our admissions department. Their expectations of treatment are going to be different from the gate. So whereas, a patient coming into our program is probably going to ask to even bypass an admission staff member and speak to myself. whereas somebody coming into another treatment unit will be satisfied to work with an admissions therapist. So one of the things that I get to do on the front, at the front door, is really start to talk to some of these patients about their denial systems. One of the first things that usually comes about is the fact that they don't feel like they can separate from their lives for a 28-day treatment stay or a full treatment length of stay that we see as beneficial for these patients. They're starting to dictate their treatment from the door. So one of the things that we really try to do, or I try to do, is really hold the line with them and talk to them about ethical responsibility to treat them responsibly, to treat their disease, to have them understand that this is a commitment, that we're not doing service to them to take them at a shorter length of care. And usually they don't acquiesce on the first phone call, but when we're able to set a boundary with them, I mean, these are usually folks that don't have a lot of boundary setting going on in their lives. They're used to dictating to other people in their lives, whether that's business or being head of a household. They're usually making a statement and people are following through. Their expectation of treatment is that's going to be very much the same. So being that we're able to sort of set that expectation for them coming into the door allows us to set an expectation for treatment. So many of them may be resistant to our parameters around admission at first, but usually we're able to present them in a way that's very respectful to who they are as individuals, their success level, their expectations around what type of treatment services they want to get, and their goals. And so we already have a personal connection with them coming in the door, and we can say to them, you know, we see you, but we also have certain expectations. So I think when they get here, we're already starting to try to dissemble some of their defense mechanisms. A lot of the times the things that they're going to say is, I just need to come in and dry out for a bit. My life is really pretty good. You know, I'm still working full time. I'm pretty successful. I've got all of these commitments and these social obligations. And really what's behind that is shame. Because they could probably get away for a couple of weeks and talk about going on a business trip. If they're gone for 28 to 30 days, people are going to start to take notice, and that stigma and that shame associated with coming into treatment is going to be something that's on the forefront of a lot of these individuals' minds. And so that's something that we're automatically dealing with, is, you know, helping them understand the importance of taking care of themselves. When they do finally get into treatment, you know, Caron as a whole, we do a fantastic job, I believe, in providing a continuum of services, starting with, you know, psychoeducation around addiction treatment, and many other different models of treatment. That said, I don't think that the Grandview experience is much different in the modalities that we're doing, but the way that we're approaching some of these patients is going to be really important. The clinical staff, we do a lot of work around their own countertransference. They're very used to working with a population that is going to be very strong in their you know, Dr. Eyre did a great job in talking about the gentleman that comes into treatment and has been on the cover of Forbes, or has been, you know, in his role used to commanding a room. They're going to come into treatment the same way, and they are not going to want to sit across from a therapist that's not going to be able to hold their own. And so part of the work that we do with these patients is really training our clinical staff to understand that this is also part of their defense mechanisms, and to start to help them, the patients themselves, to see how a lot of these characteristics have been really beneficial for them in success of finance and moving up the corporate ladder and having all the things that they have. But when it comes to stopping drinking, when it comes to healing relationships, they are going to struggle if those are the primary tools that they're falling back on. And it is a dance. These are not individuals that you're going to want to be very confrontational with, or to get in the ring with. I think Dr. Ayer talked about building an alliance with them. You know, we want to come alongside them and let them know that we appreciate everything that they've accomplished in their life. And unfortunately, the disease of addiction doesn't really care. And talk to them about coming alongside and supporting them in creating their goals, to get those parts of their lives that's not what they want them to be, to where they need to be. A big part of that challenge is also in working with the family and the family systems. These individuals are not only coming in to us usually with a family of origin, meaning, you know, the family that they've grown up in, their immediate family that they have now, but they also probably have a business family, and all have created enabling systems for them. And the business family, most of these individuals, like we talked about with having high success, they have been able to insulate themselves to the fact that they're able to function at a very high level in their company, and also be able to use or to drink in a way that's not going to be noticed, because they're not going into the office. They're taking business trips. They're doing things remotely. They have people in their organization that are making them look as efficient as maybe they once were before their addiction had progressed. Families, meaning whatever their immediate family system is, spouses, children, parents, they are also a big focus to what we do here in treatment, because we know that usually the family is that precipitating event that leads these high functioning addicts or alcoholics to treatment. Generally, they don't have a lot of legal consequences. They don't have a lot of financial consequences. If they have legal consequences, they've probably been eradicated by their financial status. You know, they are able to, you know, throw money at problems and have it go away pretty easily. It doesn't always work from a relational standpoint, which is usually what drives a patient into treatment. But the flip side to that, which is an interesting dynamic, is that the families help drive a patient to treatment. However, when we really work with the family systems, there's some defensiveness on their own part about getting healthy and about really looking at the family system that is supporting the disease of addiction. We have a dedicated family therapist here on Grandview that works with each and every patient and each and every family that comes into treatment. And we've positioned ourselves to be able to do that because we know that that is the only leverage in working with these clients that we really have. Well, in other situations where you may have a rock bottom that looks different for a individual that is not high functioning, sometimes you have a lot of leverage to keep them in treatment. You have the legal system. They may have lost a job. They may be in financial ruin. They may be out of their home. You know, there are a lot of pieces of leverage. These individuals don't usually come to us with a lot of clinical leverage. And so the family system is a big part of where we try and get buy-in. But the difficulty with some of these families is they are just as enabled, and they are just as fearful of change. So the identified patient may be the financial provider for the family, and that spouse and those children may really appreciate the financial gain that's coming as a result of this person really being successful. And so in confronting this identified patient, they run the risk of alienating them and not having some of that financial gain that the family is used to sustaining. It's difficult sometimes for the family to understand that they are part of the process. And so a big part of treatment of this type of an individual is really bringing and coming alongside the family, not only in education, but also in really doing some family systems and communication work. So those are the things within the family system that we try and work on while they're here. I also think that a big component that we take a look at, and Dr. Ayer mentioned, is addiction interaction pieces. And so while most of these individuals are very high functioning, some of those addictive qualities that have translated into their substance use have also translated into other pieces of their life. Their relationship with work and money is usually something that we see a lot of. They've been very motivated and worked and put many things put their work before many things in their life to be able to promote success. They've worked 80, 90 hours a week, sometimes more than that. And, so those are the things that are also, what we know about addiction and interaction disorders, those are the things that are also lighting up the parts of the brain that are really impacted by substance use. And so you have a lot of areas of substitution. And so one of the things that we take a look at is how has your career, how have the highs and lows of the stock market, how have the gains of being really successful in business, how has that impacted that same sort of a endorphin rush that you're going to get from a drink or a line of cocaine, and how do we need to bring awareness to that from a relapse potential? Sometimes that's also helping them understand the process of their substance use. We see a lot of individuals that are moving towards retirement. They've slowed down in their work, and as they've decreased their responsibilities at work, they've increased their substance use because the same skills they were using to fill the job was also helping them to stay away from some of those underlying issues that might be driving the addiction. And so when you take away some of the work responsibilities and we see an uptick in the substance use, those are a lot of the treatment issues that we're taking a look at. That brings me to another point, is that while they are here in treatment to really work on their substance issues, that a lot of these clients, we have to backdoor treatment. And what do I mean by that? I mean that standing up in front of them and talking all day about substance use and their addiction and their drinking is not going to be something that is going to get you a lot of brownie points with this crowd. Really talking to them and having them understand relational issues, family of origin, what their experiences have been in their life, their increased stress, their increased anxiety, looking at the symptoms of their addiction sometimes are a way you're going to be able to weave in and attack the denial system around the drinking. So we spend a lot of time doing experiential work around the drinking. And just nothing to do with their drinking. And as we continue to move along, we're able to educate them how their drinking is not going to really help them in being able to meet their goals. And I think I'm running short on time. So I want to talk a little bit about continuing care, because this is something that is really important, especially for this population. And one of the reasons that Dr. Ayer and I have, worked so closely together is that I had mentioned, and Dr. Ayer had mentioned, that rock bottom, for these folks sometimes is not really rock bottom. So they may come into treatment and, my wife wants me to come into treatment. Yeah, I get it. I'm an alcoholic. They really don't dig in and find that acceptance around their disease. They're really not willing to go to any length to stay sober. And so they come out of treatment, they may or may not take our recommendations from a clinical perspective with regards to continuing care. But if we can get them connected with somebody that is used to working with this population, can build a relationship with them, we may have success in being able to recapture them when they have continued to incur consequences in their attempts to manage their drinking, which is a lot of times what we see. The other piece to this is that I believe that here at Grandview, my staff and I do a really great job of building that therapeutic rapport and starting to plant seeds. So we are not going to be confrontational with them, but we are going to start to talk about the progression of their disease, and when things get worse, they usually know that they have a soft place to land with us. And so relationship building, getting them connected with people that they're going to bring them back to us when things don't succeed, and the family is really important, and hopefully eventually being able to make a real difference in the recovery process for these individuals. So I think that that's all I have right now.
Thank you, Sam, and thank you, Dr. Ayer. So we do have a little bit of time, and I'd like to now answer some of the questions that were submitted through the registration process. The first question that we have is, in what ways has the COVID-19 pandemic affected these HFAs and the treatment?
Sam, you want to tackle that one first?
Sure, I can. So we've actually seen a huge uptick in these types of individuals seeking treatment. And I think that there's a couple reasons for that. The first, obviously, being that I talked a bit about shame and stigma, as Dr. Ayer did as well, and really feeling like these individuals can't disconnect from their lives, and if they're gone or unaccounted for, that people are going to know where they are. Well, the beauty of COVID is it has all of us working remotely. And so there's less accountability from I have to go into the office or I have to let people know where I am, as long as I'm checking in and I'm at least visible to some extent. So the nice thing about Grandview is we do allow electronic use here on the treatment unit, not so that it impacts treatment itself, but they are allowed to stay connected in a way that's not intrusive to the clinical setting. So it has really brought in a lot of individuals that may be working remotely to come into treatment and to spend time in treatment and to work on their recovery without having to worry about the accountability piece from an employment standpoint. The other thing that we've seen, obviously, is the world of mental health is an increase in isolation and disconnect from resources. So people that may have started either the process of early recovery or tried to take a look at their drinking, and to look at outpatient sources, they may not be able to do that because, again, everything is virtual. Meetings are virtual, therapy has been virtual, and there's a struggle for them to connect and to have accountability. And lastly, there has been a huge uptick in just substance use in general with people working from home. So it's much easier for them to start drinking in the morning, utilize what they need to do to be connected to work and to continue to use or to drink. And that has become unmanageable. People in the home are starting to notice because they're at home. So I would say that we've had a lot of individuals seeking treatment that may have been able to go a little bit longer in the progression of their disease had COVID not hit us.
Yeah, so I'll just kind of piggyback on that last part that you said, is that, listen, I think the whole COVID and quarantine has impacted everybody, and that for people who have substance use disorders, in some ways it has created an opportunity for them to maybe address something in a way that they wouldn't have before. For other people is that the crutch of alcohol or drugs, they're leaning more heavily on it because there's increased stress. But I'll just share sort of an anecdote of a case that I'm working with right now. Is that a Wall Street executive, very high-functioning individual, and that spends very little time at home. He has 4 children, lovely wife, and they live in a terrific community, very nice home. But the guy works, 16, 17 hours a day, and he's away from the home a great deal of time. And there are some times where he doesn't come home. He works in the city. He might have an appointment or a meeting with somebody late in the evening, and we'll just stay at a hotel and drink in the hotel. So now none of that's going on, right? Is that he's working virtually, he's working from home, and that he's forced through this process to have to interact with his family more. And they are less willing to accept and tolerate the drinking in front of them. So the wife knew that, he would drink on the train on the way home, or if he was staying in the city, he was going to dinners and drinking. But now that it's in front of her face, is that she's less willing to tolerate that. And so she provided an ultimatum to him to sort of say, hey, listen, you've got to go talk to somebody about this. So that's what pushed him in the door to talk to me, was that he said, listen, I don't think I have an alcohol problem. I'm calling you because I just want to kind of, convince my wife that I don't really have a problem. So I'm willing to come and talk to you for a few times. I think somebody sent me a question about, kind of how much do you sort of, bend and flex, with an HFA in terms of maybe offering them, quote, alternatives, or, coming up with some type of non-traditional plan. I think, some of it's about, you have to meet the client where they're at, right? And so if a client, is kind of saying, hey, listen, I really have, my wife thinks I have a drinking problem, but I really have a kind of a marital problem, right? So I'm like, okay, we'll come in and let's talk about that, and let's kind of see what's going on. And my job is to sort of, try to find opportunities to bridge it back to the alcohol, right? So if somebody says to me that, hey, listen, I really, we have terrible communication, we're fighting all the time. And when you find the opportunity to bridge that back to the drinking, sometimes you can begin to kind of penetrate some of these cognitive distortions.
Thank you both. So this next question really kind of piggybacks off of the anecdote a little bit that you just shared, Dr. Eyre. But any suggestions on how do you influence an HFA to acknowledge a problem and to potentially seek treatment?
You want to take a stab at that, Sam, or?
So, I think generally coming into inpatient treatment is the last, is the last option for a lot of these folks, that it's much more common to have a situation like Dr. Eyre explained, where there is somebody in their life asking them to talk to somebody to get some help. And then we have therapists and outpatient providers that are able to establish a rapport with these patients and encourage them to do something different when what they're currently doing isn't working. I don't know if this was the same question, but I saw something in there regarding ultimatums. I would say that generally ultimatums don't work very well with this population, because they tend to be pretty stubborn. They tend to feel like, well, if you don't like it, there's the door type of a mentality. And they've figured out everything else in their life. They'll figure this out as well. So I think it's really more about an alignment and a support that not only a family is going to be encouraged to have, but also a clinician working with these individuals and gaining trust, so that these patients really do look to those individuals for support and encouragement when things continue to not go well for them.
I think, somebody texted me a question before about, I guess, the use of the word denial. And that, is, we bandy those words around in treatment, but it's a little bit of an antiquated piece of verbiage, is that, the implications of the concept of denial is that it can be penetrated and shattered, and that, once you've sort of been able to penetrate the patient's denial, somehow they're out of it and they'll never go back into that. But we know through social science research is that that's not true. Is that, and so what's in common use, evidence-based practice is the trans-theoretical model of change, or what's commonly referred to as stages of change model. And so, I think that part of it is, meeting a client where they're at. If they're in a pre-contemplative place, right? It's how can I get this patient to begin to contemplate that there is a potential problem? And so sometimes it's engaging a client around a topic or around an issue that might not be what is really the problem, right? So for example, if somebody, the wife says, hey, listen, he drinks too much, he's got a drinking problem, he's an alcoholic, he needs to get into treatment. And the guy says, I don't really think I have an alcohol problem, I have a marital problem. Okay, well, maybe that's an engagement point, right? That's an opportunity to connect with the patient, show that you can produce some value for the person, and then again, bridge them back to the things that maybe are some of the more primary causes.
Thank you very much. And I know we're running a little bit low on time here, but I want to get to another question and just mention for everyone who is joining us today that Dr. Ayer has been answering some of the questions in the chat box, and anything that is not answered will work to get you an individualized response afterwards. But one more question that I have here is, what are some of the impacts on children and other family members that are in the household with one of these HFAs?
So I can start. I mean, I think that there's a huge impact on the children, although I think we see a lot of denial around impact on children. A lot of these high functioning addict and alcoholics really believe that because they're providing financially for their family, and they're getting them into the best schools and providing them with the best nannies and providing them with all of these lifestyle pieces, that they're really meeting their needs, and the children are not aware of the dysfunction or the substance use in the home. Part of what we do from a family perspective is really to start to talk to the patient and the spouse or significant other about, children. All of that is done on an age-specific basis. So what's going to be appropriate for those children? But we ask about the children. We ask about the ages of the children. We ask the family what they believe the children know. Generally, it's usually pretty clear that the children understand that there is an issue. If these are older children or adult children, we're engaging them with the family therapist. We may ask for impact letters. We may invite them to our education. If they're younger children, we have a children's program that right now is webinar based, but we have a lot of information that we can provide to the families to help them begin to open communication with the children and have them understand the impact that it is having on the kids, and be able to help the children verbalize and to vocalize what it is they're experiencing. So it depends based on the age of the children, but we're always looking to engage them in the process.
Yeah, I guess I'd say for me in the work that I do is that the impact on family members, especially children, sort of is three-tiered, right? And so what one is you have the practical concerns about physical abuse, danger to the child, driving drunk, getting into a physical altercation with a child, engaging in some type of reckless or damaging behavior. Second tier is stuff that in some ways is probably harder to treat and sticks over a longer period of time, which is the emotional impact of living with somebody that has chemical dependency. And so issues around emotional neglect, abandonment, lack of connection with a primary parental figure, shame, embarrassment, hatred, things like that. Those are things that tend to kind of stick over a longer period of time for people. And unless you're prepared to, spend a few years on the couch, that's probably something that's gonna hang with you for a while. And I guess the third thing, that I see is that, for a lot of HFAs is that they're engaged in a lifestyle that begins to be emulated by the teenage and young adult children, right? So for example, you have a high functioning substance use disorder client that's primary drug of choice is alcohol, and they belong to a fancy country club, and they've got a 10,000 square foot beach house down the shore, and that, they've got a party boat that they go out on weekends, is that oftentimes alcohol is just, it's a big part of the whole scene. And the teenage and young adult children of this person begin to sort of say, that's the way it's done, right? Is that's the way, mom or dad drank, and they're very successful. So I guess this is the way that it goes on. So there's sort of a grooming of the next generation of substance disorder cases.
Thank you both very much. And again, thanks, Sam and Dr. Eyre, for joining us today and presenting on this topic. If you have any questions for Dr. Caron Eyre or would like more information on Eyre counseling, please refer to this slide. We'll also be emailing this information out to all attendees. As a reminder, we are offering continuing education credit for social workers. A survey will be posted for you to take immediately following this presentation in order to obtain the credits. Again, you must have been on for the duration of the presentation to get the credit. You'll receive a certificate of completion in the next couple of weeks. Join us next Tuesday, August 25th, for a continuation of our webinar series on the topic Caregiving, Career, and COVID-19, helping women connect and cope during a worldwide crisis. We will welcome Samantha Smith back alongside Erin Goodhart, Senior Clinical Director of Women's Services, to speak on the topic. Watch your email for details on how to register. Please reach out to your local regional resource director at any time for additional information, resources in your area, or questions regarding admission to any of Caron's programs. Our residential campuses in both Pennsylvania and Florida are open and ready to provide world-class care to those suffering with substance use disorder and mental health issues. Zero community spread of COVID-19 at any of our sites. Additionally, many services at our regional recovery centers have gone remote, but we continue to provide outpatient, intensive outpatient, and evaluations via telehealth. We look forward to seeing you in person again soon. Please visit caron.org or contact your local regional resource director for the latest on our response and preparedness to ensure patients remain safe and healthy while receiving the utmost quality of care. Thank you for joining us and have a great afternoon.